So come on up, Steph. Thank you so much.
Getting myself oriented. Thank you for letting me talk today. Hopefully learn something. So my agenda for today is for us to go over what genetic counseling is. Some people don't know what a genetic counselor is, so don't feel bad if you haven't heard of that before. I wanted to go over inheritance. Sounds like you've gone over that a couple of times today, so hopefully it's not super redundant. I'll talk about some prenatal genetic testing options and also some genetic factors that are unique to NF1 and schwannomatosis related to it. Oh, can you hear me now? Yeah, a little louder. Okay, I'll try to yell. Is this better? Okay. Just to go over what genetic counseling is and what you might expect from meeting with a genetic counselor. So this is taken, it's a definition taken from our National Society's website. We're healthcare professionals that have specialized education in genetics and counseling, and we provide education and personalized counseling to help patients make decisions about moving forward with genetic testing and their genetic health. Every genetic counseling session is a little bit different. I think the overall goal of doing genetic counseling is to help patients or people make informed decisions about genetic testing, not only for themselves, but for their family. First, we'll review personal and family history as it pertains to the genetic syndrome in question. We go over the benefits, limitations, implications of pursuing genetic testing. And of course, if you decide you want to move forward with genetic testing, we'll talk about what sample is most appropriate, talk about billing or insurance coverage or not an insurance coverage, lab selection. As many of you might know, for especially NF1 and schwannomatosis related syndromes, some labs are better than others. So we'll talk about that. And then, of course, interpretation of your genetic test results, what they mean for yourself, and then also ultimately what they mean for your family. And genetic counselors specialize in many different areas of healthcare, cancer, prenatal, pediatrics, and more. I personally specialize in cancer, but today we'll focus on genetic testing in the prenatal world, mostly. All right, so now that we know what genetic counseling is, I wanted to shift gears and talk about genes. So I think we all know what a gene is by now, but just to give you my spiel, a gene is like an instruction manual for our bodies to grow and function properly. As mentioned in Dr. Miller's talk, there are about 20,000 genes that we all have, and we need all of them to be working properly to grow and function properly. They provide instructions for eye color, hair color, and as we discussed in Dr. Miller's talk, there are tumor suppressor genes that are supposed to basically regulate cell growth. We need them to make sure tumors or cancers don't happen. So when we say someone has a gene mutation, we're not saying they have a gene or not. We know they have them. We want to know if the gene is functioning or not. So this is an example of an alphabet of a gene that is supposedly functioning properly, A's, T's, G's, and C's. But when someone has a mutation or a pathogenic variant, it's basically interrupting the function of that gene. So you no longer have that instruction that's saying, don't overgrow, overgrow or rapidly duplicate yourself. And there are many different types of pathogenic variants that can happen, but two more common ones are single spelling changes or maybe deletions of a small portion of the gene. All right, so now we know what genes are and how they're inherited. So going back to we all have the same 20,000 genes. We actually all have two copies of the same 20,000 genes. We get one complete set from our moms and one complete set from our dads. So there are many different combinations offspring can have, but ultimately we inherit both, 20,000 from mom and dad. So just to simplify, how would we inherit a pathogenic variant or a mutation in a gene? So for NF1 and schwannomatosis related syndromes, they're inherited in what we call an autosomal dominant fashion, which basically means that in theory, a parent starts out with one non-working copy of the gene and one copy that works properly. So anytime they have a child, there's a 50% chance they pass on the copy that has the mutation or pathogenic variant, and then a 50% chance that they pass on the working copy or the one that doesn't carry the pathogenic variant, affected with the mutation, unaffected without the mutation. So in the prenatal world, parents or future parents want to know, is there anything that I can do to know if my child has this hereditary condition, or is there anything I can do to reduce the chances of my child of having this hereditary condition that I have? And when I meet with patients, I think of these 3 different time points that you can perform genetic testing if we know the pathogenic variant that the parent or future parent has. So there's always the option to test a child after birth. So you can test the baby right when they're born to say, is the child affected or not? Another time point you could consider is when it would impact their care. And that's, of course, dependent on the genetic syndrome. So for NF1, for example, you may want to know right away so you can get them into established care before their first birthday. For schwannomatosis related syndromes, you may consider waiting until it may impact care in the teens, 20s, 30s, depending on what gene we're talking about. And then there are a couple options during pregnancy. So basically, you can conceive naturally or during the IVF process. There are 2 different options that you can or procedures you can complete to see if the pregnancy is affected by the genetic syndrome or not. Chorionic villus sampling or CVS, or amniocentesis or amnio. So if you aren't familiar with what those are, just to give a very broad overview of what samples you're taking from for each procedure. So for chorionic villus sampling or CVS, this is generally done between 12 and 14 weeks, depending on the centers, maybe a little earlier, maybe a little later. And it's actually taking a sample directly from the placenta of the pregnancy and then completing genetic testing on that sample. Do the cells in the placenta carry this gene mutation or not? There are, of course, limitations and complications with any procedure you might perform on a pregnancy. There is a possibility that the genetics of the placenta are not the same as the pregnancy. So that could result in a false negative or false positive or just different genetics altogether. And then with any more invasive procedure you complete on a pregnancy, there is a small risk for miscarriage. For CVS, there's about a 0.2% chance. And then for amniocentesis, this generally is done between 15 and 18 weeks or maybe a little bit later. And instead of taking a sample directly from the placenta of the pregnancy, a needle is guided into the amniotic sac and amniotic fluid is taken out and the genetic testing is done on the amniotic fluid. The amniotic fluid should contain DNA of the pregnancy because the pregnancy is constantly kind of drinking and peeing out that amniotic fluid, or I guess that's not exactly what happens, but typically there's DNA that's sloughed off from the pregnancy. So there are, of course, risks and complications for amniocentesis as well, false negative, which is, of course, rare. And again, a small risk for miscarriage, about 0.1, 0.13% or lower, again, depending on the center. And then there is this time point before conception. So of course, there's always the option of adoption or sperm and egg donation. That doesn't require knowing the gene mutation or pathogenic variant because that child wouldn't be biologically related to the affected parent. And then there is this cool option of pre-implantation genetic testing or PGT. So what is PGT? So if you aren't familiar with this term, it's really doing genetic testing of embryos created outside the body during the in vitro fertilization process. The goal is to test embryos to determine if the embryos are affected by the genetic syndrome, carry that gene mutation or not. And they essentially would only select for embryos that don't carry the gene mutation, which basically ensures that the offspring would not inherit that genetic condition. It sounds really simple and I think really cool, but it's a very involved process. So again, every center is a little bit different, but just to give you a basic timeline of the PGT process, there's about a 6 to 8 week window at the beginning where you first meet with the healthcare provider to talk and make a personalized plan for your family about moving forward with PGT. You need to come in knowing your gene mutation or pathogenic variant, and it doesn't just involve you and your partner's sample. It generally involves testing family members as well. The goal is to make a very targeted specific test, a fingerprint that they would look for in the embryo, not only looking for that one particular gene mutation or pathogenic variant, but also looking at the genes surrounding it to really ensure this embryo does carry this condition or not. So it's a pretty complicated process, and that whole creation of the unique test takes about 6 to 8 weeks or maybe longer. And then maybe about 30 days or half a month to a month to start the IVF process for stimulating the ovaries and removing the eggs, fertilizing them in the lab. It takes about, again, 15 to 30 days. And then the process of PGT happens. So once the embryos are created, this is a picture of an embryo under the microscope. At day 5 is when they remove some cells from each embryo that's survived till day 5. The embryo is about a couple hundred cells big. So they just take a couple of those cells from each embryo. And they also use the sample to grade the embryo on an F to A scale, like in school. And they also do genetic testing with that customized fingerprint that they created at the beginning of this process. And then they put embryos into the 2 categories, affected and unaffected. And then they also, again, grade those embryos, whether they're really good, they get an A, or whether they're, potentially not going to survive as, C, D, F. And then ultimately, if you have an embryo that's unaffected, that is graded well, that is transferred and hopefully will result in a healthy pregnancy. So it is a very complicated process. Generally, they quote between 3 to 4 months per cycle, up to 6 months per cycle. And unfortunately, there's no way to guarantee that there aren't complications at any one of these time points. So it's possible you get all the way to the end of the PGT process and you only have affected embryos, or maybe your unaffected embryos are not graded very well and wouldn't survive the implantation process. So there's a lot of factors that go into a successful PGT process. And of course, this is all if the pathogenic variant is known, and also if the pathogenic variant is a candidate for this PGT process. So as I mentioned, most of these options, most of these options would only be available to a family if the pathogenic variant in the causative gene was known in NF1, NF2, LZTR1, or SMARCB1. Some of you may have experienced this, but finding the pathogenic variant in some of these genes can be complicated for these genetic syndromes. Sometimes we can very easily take a blood or saliva sample, we call that a germline sample, and find the causative pathogenic variant. As again, many of you know, up to 50% of cases for these genetic syndromes, the pathogenic variant is new in that person. We call that a de novo or a sporadic case. And that means they didn't inherit this pathogenic variant from their mother or father, and that it occurred for the first time in that person, that child. When a pathogenic variant is new in a person, it's more likely that genetic syndrome is mosaic or segmental. We've heard that term a couple times today, which means it exists in some cells of the body, but not all cells of the body. This is more common in schwannomatosis compared to NF1, but is still a consideration in NF1, of course. Here's my spiel about mosaicism. So as I mentioned, mosaicism basically means that the pathogenic variant exists in some cells of the body, but not all cells of the body. It means that when sperm and egg meet and turn into an embryo that didn't inherit let's use NF1 as an example, an NF1 pathogenic variant from either mom or dad. But really early on in embryonic development, when the cells are rapidly dividing, I think this is a 16 cell stage up here, one of the cells acquires a gene mutation, and using NF1 as an example, the NF1 gene. And that cell goes on to turn into some portion of that person's body. And then the other 15 cells go on to turn into the rest of that person's body. And it's really tricky to know where that cell that carries that gene mutation landed and where the unaffected cells did. So sometimes when we do genetic testing on a germline only sample, blood or saliva, the cells that make blood and saliva truly don't carry that pathogenic variant. So you could have a negative germline test, but still be mosaic or segmental for one of these conditions. So the way we combat this in the genetic testing world is we do genetic testing on affected tissue. Oh, just the little spiel here. So that going back to the looping in the prenatal piece, even though a germline sample could be negative, if a sperm or egg cell is affected, it would result in a child that has, we call it a constitutional form of one of these conditions, meaning that it exists in every single cell of their body. So if someone truly has a mosaic or segmental form of one of these conditions, it's really hard to quote what the risk of passing it down to the child is. We say 0 and 50%. Some papers are smart and say maybe between 5 and 10%, but it's very dependent on the case. So going back to how we combat genetic testing for mosaic cases. So ideally, we want to test affected tissue and then compare it to a germline sample, again, blood or saliva. Using NF1 as an example, we can do skin biopsies of 2 different caveolae spots to see if there's anything consistent across those 2 spots, and then again, compare it to a germline sample. This is a very simplified genetic test results. But so using blood as the germline sample, that could come back completely negative, as I mentioned. And then looking at skin biopsy A and skin biopsy B, again, we have 2 copies of the NF1 gene. So you would need 2 mutations or pathogenic variants for a caveolae spot to happen. So we would expect there to be 2 different mutations in the NF1 gene always when we do genetic testing on a caveolae spot. What we're really looking for is if there is the same mutation or pathogenic variant across each sample, because it would be, I mean, not impossible, but very, very unlikely that you would acquire a sporadic NF1 gene mutation that's the same across 2 separate biopsies, 2 separate caveolae macules, because the NF1 gene is thousands and thousands of letters long, and for 2 different caveolae spots to acquire the same mutation, again, possible, but super unlikely. So if we see consistency across 2 samples, we know that that is the mutation or pathogenic variant the person is born with. And that can now give us more information about what's causing that patient's genetic syndrome. I hope that makes sense. The same logic can be applied to schwannomatosis related conditions if tumor samples are available. That's the affected tissue in schwannomatosis related conditions. So coming back to how this can affect prenatal genetic testing options. When someone is mosaic and the result is truly just in affected tissue, it can affect the prenatal testing options that are available to a person. This information is sufficient for testing a family member, an offspring after the offspring is born, and it can be used during CBS and amnio, but it may not work for PGT testing because of the type of sample that's required to design that very customized test for the for testing the embryos. So it unfortunately is potentially a limiting factor for PGT, but I've heard they're getting better. But it is, again, a limiting factor in whether your family is a candidate to pursue PGT. All of that, I was told to keep the talk a little shorter for questions. So I wanted to say thank you and invite any questions you might have. Are there any questions?
Might have looked all 3 at this time.
Oh, yeah, if there's. Do we have a microphone? or
Any questions?
yelling?
Amazing.
In the prenatal, the amnio or the CVS, would a patient have to ask to have that type of testing performed? I mean, what would be the, like, how would you anticipate if you're not aware of it or, I mean, because they go through like different genetic testing, but I'm not aware that this is done, like to test for NF1 or NF2.
It would, so full disclaimer, I'm not a prenatal genetic counselor. So every center is different. I know I've said that 5 million times by now, but generally, my understanding is that if you have a NF1 or an schwannomatosis related syndrome that you want to test a pregnancy for, you would have to ask your OB for the amnio or CVS. They don't.
Not aware of any of that.
If you don't know you have that genetic syndrome.
Right, or it's sporadic.
Sure.
Right.
Yeah.
I don't think they're doing exome testing.
I'm sorry. They wouldn't be able to complete it if we don't know the gene mutation for CVS and amnio. So
Can NF1 be tested in genetic testing in a CVS, just in a normal procedure?
Yeah, I think that, I think I know what you're asking, because this comes up a lot, like nowadays, for the last few years, people get what we call like cell-free DNA testing. So you can get like a blood sample from your arm. It's very similar to that liquid biopsy thing I talked about. It's like the screening for, is there some genetic disorder? That's the way they present it to people. But the problem is that test doesn't look at the NF1 gene or the NF2 gene. So if you don't already know about a risk of it from the family, nobody's going to be looking for these genes. It doesn't happen automatically.
And I mean, if you're testing for genetic disorders in a CVS, for example,
Mhm.
why not, like, is it not easy just to throw in the other
Do you want
test?
to take it or?
Because it would save so much time in the beginning at first.
In theory, I can understand what you're asking. So the idea is, why not just screen for all the genetic things that are possible? And the problem with that is that there are literally thousands of different genetic disorders. And so you would basically have to read all the books in the library looking for a spelling change. Each one of us sitting in this room, out of the 3 billion letters of DNA that we have, at 3 million different places, we're all different from each other. So in other words, I have 3 million genetic differences. They're not all in disease genes, but it gets very complicated to sort that out in a prenatal testing situation. And that's why we don't test for everything. It would result in everybody during their pregnancy getting back some kind of concerning result that they don't know what to do with.
Yeah.